everyone. We're gonna definitely give it a minute for folks to join, but I'm Olivia All from the Office of Banker Services. Great to see you all. If you are able to put your name and any organization you're affiliated with, if any, in the chat, that would be helpful to get to know who's in the room with us today. And we will go over the agenda in just a moment. I also recommend getting yourself a snack. If you're that type of person, I know 3 o'clock, I have my dark chocolate covered almonds here, little boost for the afternoon for this this hour and a half long meeting about rates. So it'll be something to a feat of strength for us all to really pay close attention and take this opportunity to provide some great input and learn about the next steps for our mobile crisis reform. So I'm really excited we're here today. It's been a long time coming, and I am very enthusiastic about what today will bring in the next few weeks and months for this work. I'll go ahead and get started, although I'm looking to see if maybe Stephen or someone in the room with folks are having any technical issues that I should wait on, or if they're okay.
Things seem to be working well so far, so I'm going to try not to jinx it, Olivia, but the technology seems to be holding up.
Okay, all right, just didn't want to go too fast if you're struggling in the office building. Stephen is with us, some of us, in Augusta, Maine today, so that's exciting. So just to orient everyone, again, welcome to this meeting. We are here after many years of working together to discuss the proposed rate model for what would be the reformed mobile crisis response team service. And you'll be hearing the culmination of, again, many conversations over many years. And we appreciate all the time that you put into this model. You'll hear a recap of what this new service will look like from Kylie Wilkins, who's been working with the department over a few years, and you should be familiar with Kylie. And we're going to hear about, again, what is this new service? How is it an improvement upon current services? What's it intended to do as far as what are the outcomes we're looking to achieve? And some basics about the provider requirements that are part of this new service. That's important context that, again, shouldn't really be new information for those of you that have been with us for the last year or so, because we've been talking about this model for some time. But just to give you a refresher, because as we go into the rate setting conversation where Stephen's going to present the proposed rate model, it's important to have in mind the fact that we're talking about a future state that does look different than the current state. And so the rate model is very much different than the current billing that you all do under crisis resolution services under Section 65. So very much a departure from the billing structure of current crisis resolution into a new billing structure proposed for the reformed mobile crisis work. I also want to say that MaineCare is hosting this meeting today, but we're absolutely entirely in partnership with the Office of Child and Family Services and the Office of Behavioral Health. Their teams are on here too. And so we'll be talking a little bit about the DHHS support for crisis services overall. And we have those team members here today who can chime in as much as they want during the presentation. So with that, I think, unless Stephen wanted to say anything before we go into Kylie's presentation. Okay, so I think we'll have Kylie again reorient us to what the new model looks like.
Thanks, Olivia. And it's so nice to see so many of you. I told Olivia earlier, I feel like this is kind of like the thesis presentation after doing a crisis PhD program. This has been such a learning experience, and it's been such a joy to do that alongside all of you. I'm going to share my screen. All right. And are you all seeing my presentation? Great. So I'm also really excited that I get to debut the Office of MaineCare Services new logo and PowerPoint slide deck. It has been an amazing opportunity to work with MaineCare throughout this process, and I'm really excited about moving forward through our crisis system reform efforts. So this should not be new to folks. The mission of the crisis system is something that we all agreed on, and it is to ensure immediate, equitable access to welcoming, hopeful, trauma-informed, recovery-oriented behavioral health crisis services in the most supportive, least restrictive setting. We want to ensure everyone gets the right response every time, prioritizing safety and future well-being. And we also agreed on some guiding principles that safety is foundational, and it's not just safety for the individual, but safety for the crisis response staff. We want to make sure that everybody is feeling safe, and that safety is more than just physical safety. It's also feeling like safe to be your full expression of yourself, and that you're going to be received well, regardless of your cultural, linguistic background, your sex, gender orientation, etc. We understand that the crisis is more than a single event, which is really at the center of the work that we've done, understanding that when somebody is in crisis, there have been events leading up to that crisis, and there is need beyond the initial crisis intervention. And we want to make sure that our crisis system has the capacity for complexity, meaning that we want to serve all people regardless of their co-occurring conditions or other comorbidities. So this also should look familiar to many of you, and I'll just reorient those of you who are new to our team, that this work as a result of a mobile crisis planning grant through the Center for Medicaid Services. In 2021, the American Rescue Plan amended the Social Security Act, adding a section to allow states the option to provide qualifying community-based mobile crisis intervention services. So MaineCare's mobile crisis intervention services are designed in alignment with the best practice and CMS standards. We understand that not all mobile crisis intervention responses will meet the requirements for this qualifying model, and they won't all be eligible for the increased federal match that were allowed as a result of this. But we did want to make sure that our new model incorporated all of these components so that we have a multidisciplinary team, that all the team members have the training that is required through CMS, which is trauma-informed, cultural safety, de-escalation, and harm reduction, ensuring people's confidentiality. We want to make sure that our teams are maintaining relationships with relevant community partners, and that we have standard practices to ensure consistent care delivery. So again, we built our model with the idea that we want there to be this qualifying service, but we also understand that not all crisis services will be able to be rendered with the qualifying model. So that brings us to the eligibility. So eligibility for the new mobile crisis services, because of the way that the amendment is written, the federal authority allows us to waive the any willing and qualified provider requirements through a state plan amendment. And we're proposing that these services will be eligible only to the competitively selected providers who have a contract with OCFS and OBH to ensure that all Maine people may be served by the regional providers regardless of their insurance status. So we did develop this as a MaineCare eligible program, but we also want to make sure that those who are uninsured and those with private insurance have the same equitable access to this compassionate care. And then the other piece is that we're going to retain the crisis resolution services for crisis response outside of this mobile crisis team. So the mobile crisis teams are meant to serve people and go to them in their home or community. And then we also understand that there are other times when other providers might be doing crisis resolution services, and we wanted to retain that in the section. So the eligibility pieces as well. We're not going to be asking to verify people's MaineCare eligibility until after the individual is stabilized, and that the service is going to respond to folks with mental health and substance use related crises. And it doesn't require a formal diagnosis, because one of the key tenets of the mobile crisis policy is that a crisis is self-defined. And so some individuals may not have a behavioral health diagnosis, but they may still be in crisis. So to expand on the provider requirements, there needs to be a valid license for the provision of emergency mental health services through the Division of Licensing and Certification, available 24 hours a day, 7 days a week, 365 days a year. That's like our current service. We also want to make sure that there's trauma-informed responses for all people, meeting them with unconditional positive regard and cultural humility. And then for children, we're wanting staff to be consistent with the principles of positive youth development. We want to ensure that staff meet all the training requirements that I mentioned from the CMS qualifying standards. And then we also want folks to maintain relationships with a range of partners. And so those partnerships can include criminal justice and judiciary partners, medical partners such as regional primary care and hospital organizations, regional community action programs, food security programs, housing programs, general assistance programs, agencies and entities that serve special populations, such as tribal partners, the Office of Aging and Disability Crisis Services, regional domestic violence and sexual assault response programs, cultural and linguistic partners, deaf and hard of hearing partners, etc. So the Office of Behavioral Health is spearheading a new crisis responder training curriculum. They're working with an amazing consultant, Jess Dolman-Rainey, who has developed this framework, which should look pretty familiar to folks who have been involved in those focus groups. So the crisis team members must complete the department-approved crisis response training within an approved timeline. It has to include those things that we mentioned before: de-escalation strategies, culturally affirming care, harm reduction. This includes naloxone administration. The comprehensive tiered training structure incorporates national best practices. So that's all reflected in the new policy, and it's going to be reflected in the new curriculum as well. There were listening sessions hosted before developing the content. It's designed with current and future national certifications in mind. So crisis is an area where there's a lot of research and a lot of emphasis since 2020, and it's a developing field. So there will likely be national certifications, and Maine is in an advantageous position because once the national accreditations are implemented, folks won't need to retrain because we're going to design our curriculum with that in mind. It's built as a core training with electable practice focuses, clinical or peer, and there are stackable focused credentials. There will be waivers designed for current staff who already hold the mental health rehabilitation technician crisis service provider training, and deadlines will be designed with staffing realities in mind. And the training is delivered in a hybrid format. Much of that is online and self-paced, but there will be some interactive components, as well as a practical job shadow requirement, which the current model that most organizations utilize today. The draft curriculum will be ready this spring. Stay tuned, and if you have questions, you can connect with Bree Maselli, Brooke Pochi-Smith at OB8. They can be your liaisons for the responder training. So the mobile crisis intervention response services must be furnished by a multidisciplinary team, which means that for every shift, we need at least one crisis supervisor, so someone available 24/7 who's in that supervisory position, and at least one dispatch coordinator on call 24/7. And then we need a crisis response team, which consists of one crisis responder with a licensure or conditional license and or certification whose scope of practice allows them to conduct an assessment described under state law, and one co-responder who's typically a peer support specialist or another responder. I want to make something clear that the dispatch coordinator is a discrete function for each shift. A dispatch coordinator should not be responding to calls, so you shouldn't be out on a call and then also taking dispatch calls. However, the staff who's credentialed to respond to calls may act as a dispatch coordinator. So just making sure that you have someone who can take the calls and coordinate the dispatch and also have the appropriate number of people to go out so that the dispatch coordinator doesn't need to go out. We also want to ensure that providers do their utmost to provide a two-person response of a qualifying multidisciplinary team. And when possible, offer a peer response appropriate for each individual involved in the crisis, such as a family or a youth peer support, a certified intentional peer support person when it's an adult. So just ensuring that the teams are truly multidisciplinary and are able to meet all people. This is where it gets exciting. We worked really hard to figure out how to create this comprehensive service, and I'm really grateful for all of the lessons that I've learned about how to do that with Medicaid billing. Thank you for your patience, rate setting team. So we're looking at an initial encounter and then follow up. And so in the initial encounter, there are these different stages. And so every person who is deemed appropriate for a mobile crisis response should receive an engagement, which is the development of a therapeutic relationship within the context of their family, culture, and community. And this can be like where somebody's crisis response ends. They have their encounter, they get their connection, they are engaged, and they feel like they have somebody in their community that they can talk to and that they're connected to. But every crisis is different. We know a crisis is self-defined. And so there may be all of the components of initial encounter for an individual in crisis. So someone might need de-escalation to divert from criminal justice or hospital systems. If they're really elevated, we want to make sure that they are able to self-direct their care, communicate clearly. And then assessment and planning should begin really at the same time as engagement. You're going to be gathering information at the time that you meet with the person, immediately gathering from all available sources, focusing on the most acute issues. This can include conducting medical screening when appropriate, and engaging supports for a near term and building a solid follow-up plan. So everyone who has a crisis engagement and wants to engage further in the assessment and planning should have a crisis plan at the end of their initial encounter. An intervention may include screening, so explicit screening for suicidality, safety planning, lethal means safety planning if required, or transporting a member to receive additional care. So if through your assessment and planning, you determine that they could benefit from crisis residential, but they don't have a ride, transporting the member to the crisis residential so that they could receive that level of care would be appropriate as an intervention. And so then after the initial encounter, you've met with the person, you've de-escalated, you've done some planning, you've talked to collateral contacts, you have a great crisis plan in place, and there is a connection to follow-up care. You can then follow up with the person as an aftercare, and that can either be providing them with the opportunity to ask questions or clarify their information in their plan, connecting, making sure that they got to the appointment that you had set up for them at the CCBHC, if that's what you determined was necessary. And it can also be that you only have aftercare if somebody is stepping down from a more acute level of care. So if somebody had been in an inpatient setting, they could qualify for a crisis aftercare. If they return to community after an inpatient setting, you can provide aftercare for that individual. The encounters include resolution of the precipitating crisis event, and it typically covers the first 24 to 48 hours. Members may have another crisis that could warrant another encounter service. So just because somebody had a discrete crisis, you resolve that crisis and it's still within, a week, they could have a new crisis that would have a new initial encounter if it had different factors leading up to it. Aftercare can also include elements of de-escalation and intervention without warranting that we start a new initial encounter. So if it's all related to the same event, and when you're doing your follow-up, you're connecting with them after the initial encounter and they seem escalated, you can do de-escalation strategies with them. You can come up with new interventions that would still be part of that one crisis service. We definitely intend to have further conversations about how we frame the initial encounter and follow-up and aftercare, as we're trying to work on appropriate billing guidance and make sure that it's very clear of what an initial encounter is versus what aftercare is. So we're looking forward to your comments. So here are some national best practice performance measures. I really like this format because I love that it's easy to remember with access to help, which is what we're trying to do in mobile crisis services. Every system has its own values, and crisis systems involve multiple stakeholders. So it's essential to develop consensus in defining our system and services desired outcomes. Our senior leadership is currently reviewing a proposed measurement framework with input from partners and stakeholders. So our senior leadership team will define success and agree on how it's measured, keeping SMART goals in mind. Here are some potential mobile crisis performance measures. We want to make sure that what we're measuring is incentivizing great care. So we're looking at things like response rate, ensuring that referrals that are accepted by Mobile Crisis do get that response, at least that initial engagement. And that engagement can look like wellness checks, community education, a crisis intervention, or a drop-in at an agency or another setting. We want to make sure that we have good linkage to supports. And that's a really important piece of the Mobile Crisis model, is warm handoffs to another level of care or more appropriate community-based care. And timeliness of response, we want to make sure that everybody has timely access to these services. We will definitely have exclusion criteria in some of these examples. So in the response rate category, there will be some referrals that would not be accepted due to redirection to other state-run services. For example, if it's a known OADS client who has the appropriate, who has already had engagement in the OADS crisis system, you might just refer them to the OADS crisis system. Or if it's a clearly a child protective issue, they might be redirected to child protective services. Other exclusions might include, in the linkages to supports category, people who refused care, like you made an attempt, but they refused that linkage, or people who were immediately transferred to a higher intensity service. I'm going to pass it over to Olivia to talk about the next piece, because this is her area of expertise.
Thanks, Kylie. And so we will have more conversation, as Kylie said, about the performance measures in a separate venue. Today, what we wanted to do is focus on the fact, just on sharing that there will be a value-based, performance-based component to this model. And in general, what we're thinking of doing here is very similar to what we've done in many other behavioral health services in the last 12 months, is where we, through a process, roll out pay for performance, where there are two levels of benchmarks for what we expect providers to achieve as terms of the quality of their service, which would be measured by some of those performance measures discussed. So essentially, over a period of time, we would set an appropriate benchmark for a minimum standard of what we expect quality to look like within this model. As if that minimum standard is met, you receive the full rate. If a provider is able to achieve a very high level of quality, they would be eligible for a potential up to 1% additional funds as essentially a bonus for meeting that high level of quality. These things are subject to some appropriation conversations, but that is the general framework we are proposing. When we talk about performance measures and setting benchmarks, all of this happens after the rule adoption. So it'll be important to see the slide that Kylie has next, because we're not talking about something that turns on and becomes real to you very quickly. It's a process by which there's a rulemaking, there's a rule adoption, there is data collection or setting the baseline, and then there's notice given, and there's regular reporting provided, so the providers are very clear on what their current status or the current data tells us about the performance. So that they're very much in the know about where they are sitting relative to the benchmark. And then eventually, no sooner than 6 months, it generally takes almost a year after rule adoption, does the actual performance-based payment model kick in, where there's a withhold, again, until there's evidence that you've met the minimum standard or the higher standard to receive additional funds. So we're not spending a lot of time on that today. That's the standard framework we've been using at MaineCare for these models. But just so you know, that would be an element. There will be further conversation about the performance measures, and all of this is quite a bit in the distance.
Thanks, Olivia. And now our proposed timeline. So spring 2024, we're looking at the MaineCare rule proposal, and then summer of 2024, we're hoping for MaineCare rule adoption. Same time, we would be looking at the publishing of the request for proposals for the service, and then in the winter of 2024-2025, so like December, January timeframe, we're hoping that we would have awards issued and the service to begin. So we have come a really long way from where we started on our mobile crisis planning grant efforts, which involved just the very beginning of gathering all of the information of what was currently happening and how to get the gaps to goals analysis to our qualifying mobile crisis standard. And now we are looking forward to, the rule adoption and the rulemaking process. So we're really looking forward to your comments regarding the rate, which Stephen will discuss. And I just want to say a big thank you to everyone for engaging in this process with me and for being patient as I learn how public policy and rulemaking works within the Medicaid structure. It's been an absolute joy to work with all of you, and I'm really grateful for the opportunity to improve our system of care and hopefully, save lives. This is life-saving work, and I'm really grateful for all of you who do it every day. You, Stephen.
Thank you so much, Kylie. I'm going to share my screen now. And just bear with me for a moment to find my presentation amongst the jungle of windows I have open. Kylie, I can still see you. Am I showing my full screen to you? The slide and presentation view?
So, and not in presentation view.
Okay. I'm just gonna, I don't know why it does this. I'm just gonna work from this version. Okay. Good afternoon, everyone. I'm Stephen Plowski. I'm with the Burns and Associates Division of Health Management Associates. We've been working with the departments on this project now for a bit better than a year. Really grateful for the opportunity to present some preliminary recommendations to you and to kick off a public comment process. In terms of what we hope to accomplish with the duration of this particular meeting today, we're going to be presenting, well, let me provide a little bit of background. This is part of a larger project through which the department is looking at the reimbursement for behavioral health services covered under 1728-6592 and then targeted case management under section 13. We ultimately pulled the work out and put it on a different time frame for mobile crisis services, as is now quite apparent for a number of reasons. The largest of which is because of the co-occurring changes to policy that Kylie's done a great job of summarizing here for us at the top of the meeting. But because that ultimately ended up on a different time frame than the work for the other sections of policy, we pulled this work out so we can not hold up the other services that were subject to this particular project. My firm, Burns and Associates, is working with the department both on the larger rate study, which of course has been published. Implementation has happened on that, as well as on the work specifically related to mobile crisis. For those folks who've been involved, whether it's in the larger behavioral health project or any of the other rate studies that we've done with MaineCare over the years, we're following the same approach that we always employ. Obviously, the results are different, and in this case, you'll see some differences to how we envision the service being billed. But the bottom line is we put forward some detailed and transparent rate models that you can use to identify the specific assumptions that we've made in order to develop those bottom line rates. So we go beyond just publishing a fee schedule. We're showing you the work that went behind the rates that we've recommended to this point. One of the things that I'll expand upon a little bit more in a couple of slides is that we're looking at data from a variety of different sources. So we conducted a provider survey. We have existing provider cost reports. Obviously, there's the work that Olivia and Kylie and others have done to talk through the changes to policy that we've tried to take into account within the rate model. And then, of course, some published sources of information that we typically rely upon as well. And then ultimately, we endeavor to include stakeholders at each stage of the process. Of course, that's now a MaineCare expectation, but it's something that we've always employed within our projects. In terms of the presentation itself, we'll summarize the process. I'll try very hard to get through that pretty quickly. I know many of you have heard this presentation a time or 3 or 5 before, but for those of you who perhaps not been part of these calls, I do want to spend a couple of minutes walking through the process. And then, of course, we'll emphasize the draft recommendations that we're putting forward. I want to emphasize that this kicks off the public comment process. We've never gone through a rate study where the public comment process hasn't resulted in some changes which were originally proposed. So this is very much value added. And in this case in particular, we're looking for feedback not just on the rates themselves and the assumptions that went into the rates, but as you'll see, some changes to how we envision the service being billed. So probably of at least equal importance is thinking about that overall billing structure that we'll be talking about here in a few minutes. But those comments will be considered before any final recommendations are put forward. In terms of the agenda, it more or less is what I just said. We'll talk a little bit about the background of the project, the process that we employed, and then we'll walk through the draft recommendations and wrap up with particulars of the public comment process. In terms of the background, again, many of you have heard this spiel before, but MaineCare has been conducting rate studies like this, whether with Burns or with other consultant firms, for a number of years now, and that's part of their commitment to ensure reasonable and fair rates so that Mainers who rely upon MaineCare have access to the services that they need. In 2019, the department launched a comprehensive rate analysis with a different consulting firm that was yet used to guide the rate setting process through benchmarking work, conducting regular updates of the rates through some cost of living adjustments, moving away from cost settlements in most circumstances, and ultimately holding providers accountable for cost and quality along the lines of what Olivia did a little bit of previewing on towards the end of that presentation. In addition to that work, the legislature adopted, or passed, I should say, statute that also now provides some additional parameters through 4 rate studies like the one that we're talking about here. Nice thing is it's largely consistent with the way that we've always done business, and I think the way that MaineCare was already doing business before that legislation passed. Without getting into any of the details of that, I just want to point out the very last bullet on this slide, which is the legislation requires this comment process before the rulemaking process begins, at which point, of course, you have another opportunity to provide comment through that formal rulemaking process. That's always been our approach. We always like to have these initial recommendations out for feedback from providers and other stakeholders with an interest in it, so that by the time we get to rulemaking, hopefully there are no surprises and no issues are raised during rulemaking that haven't already been raised and considered. Briefly, and perhaps the least interesting slide, a little bit about us. Burns & Associates is a health policy consulting firm. We were founded back in 2006, and since our founding, our focus has always been supporting state Medicaid agencies and their sister agencies, the Developmental Disabilities Authority, the Behavioral Health Agency, the agency that provides services to older people as well as people with physical disability. So year in, year out, that's probably 95% of the work that we do is partnering with state government. The reason for the mouthful of my introduction and then the branding at the bottom of the slide is we sold our company to Health Management Associates in September of 2020. So some of you who've been working with us a long time knew that we were a standalone consultancy. Now we're part of a much bigger firm, but it's still the same Burns staff working on the same Burns projects with the same Burns clients. So although we're in a different organization now, the work itself is as it ever was. A big part of our work over the years has been rate studies like this, and that's always what generates the most interest, because anytime you're talking about how much to pay somebody for something, people are going to have an opinion or two about that. Within the Medicaid space, we like to say that if Medicaid pays for it, we've probably set a rate for it at some point in time over the years, but we've done an awful lot of work, particularly for home and community-based services, broadly defined, so including things like behavioral health services. We also do facility rate setting, hospitals, nursing facilities, and the like from time to time. And then even sometimes we wander outside of the Medicaid space and have been involved in child welfare projects or child care related projects. We've worked with Maine for a very long time, so this slide becomes more and more dense every time I put it together. But this just shows the projects that we've been engaged with or engaged by MaineCare to provide assistance on over the years. So a brief summarization of what sections of policy were included, when it was conducted, and the extent to which those rates were or were not implemented. Of course, relevant to this conversation, we did take a look at crisis services under Section 65. That also envisioned some changes to how things like the crisis hotline was established and other provider qualifications. So ultimately, most of that rate work did not go forward. And of course, then if we move towards the bottom of this slide, we did the work for the balance of the behavioral health care system, more or less, most of the balance of the system through that review for 13, 17, 28, 65, and 92, and those rates have been adopted and moved towards implementation. I myself have worked on every one of these projects, I think. I've been with Burns & Associates 2009, I guess, so about 15 years now. Prior to that, I worked in state service in the state of Arizona as the chief financial officer of their Department of Economic Security, which is their human services umbrella organization, as well as a couple of years in the governor's office before that. So kind of been in this health and human services and Medicaid space for quite a few years now. So this process, again, is generic. This is what we always employ when we're doing these types of rate studies. As I mentioned already, we refer to the approach as an independent rate setting approach, which means we're not dependent on a single source of information. And what we're really getting at is what I said on my initial slide, which is we're going to look for information from a variety of different sources so that we're hopefully providing a true representation of the cost of delivering services. And we know that a provider's existing cost structure might not be fully consistent with the delivery of high quality services because oftentimes your costs are going to be constrained by the rates that you're being paid. So we certainly spend a lot of time and do rely upon information gathered through things like cost reports and the provider survey that we administer, but we're also going to look for other information as well. So as we'll talk about, we use things like the Bureau of Labor Statistics as a starting point for building out wage assumptions. We'll conduct special studies. So we did some work, for example, looking at how other states reimburse their crisis system, and then we'll include provider and stakeholder feedback through things like the public comment process that we're opening up here now. Fundamentally, our goal is what's articulated in the middle bullet, which is we want to build rates that reflect the reasonable cost providers incur to deliver services consistent with the state's requirements and individual service or treatment plans, right? It's the state's job, in our opinion, ultimately to define their services, but once they do so, we think they also have a responsibility to pay rates that allow providers to deliver on those standards and on those expectations. I'll also note that we always build rates independent of budgetary considerations, so we don't take projects if the state says you need it back into some specific number. Now, given our backgrounds, we're not ignorant of the financial implications of recommendations that we make, but if things need to be scaled back, we do that in a transparent fashion. So for example, a number of years ago when we did work for personal assistance services, the state couldn't afford to fully adopt what we recommended, but over a period of time, investment was made so that we got back up to those initial recommendations. We see a number of benefits to approaching the work in the way that we do. The first, and we hope that we largely get buy-in at least on the transparency of the work that we do. So I suspect that we're not going to have agreement on everything that we recommend or every assumption that we make, but at least folks are going to know what those numbers are and the sources upon which we rely to develop those figures. And then furthermore, once you have rate models that are developed in this fashion and that are transparent in terms of what the cost drivers are, you can make targeted adjustments over time to update those rate models. Those might be to advance policy goals. So it could be, for example, down the road, the state adds some new training expectations and you can remove the training expectation we have in rate model. Let's say it's 50 hours per year and the state says, well, I think another 8-hour module will be helpful. Then you replace the 50 with a 58 and the rate models themselves automatically recalculate. Or it could be a matter of simply updating the rate models to keep pace with cost growth. So you can make targeted adjustments. So as folks are aware, MaineCare is now required to set rates that allow for paying staff at least 125% of the state's minimum wage. That goes up every single year. So if there was a rate model, certainly doesn't apply to anything we're talking about today, but if there was a rate model that was at the 125% level, as that minimum wage gets updated each January 1, the state could go in and replace the old standard with the new standard again without having to go through a lengthy and costly rate setting process. In terms of the process we employ, this graphic illustrates the major phases of the work, which are color-coded. We always start with doing background research and then having some initial meetings, which we had both with the states and then with many of you on this phone call to talk about the existing system, what's changing, what people think is working well, what they think is not working well, what strengths can we build on, what deficiencies do we need to address, et cetera. Then we move on to data collection. That includes our ever popular provider surveys, as well as other research and analysis that we conduct to complement that primary data collection. We then move to where we're at today, which is the development of our initial or draft recommendations, which, as I've said a couple of times, and we'll close my comments on here in a little bit, it is then moved to a public comment process. So I can't reiterate enough how important your comments are to the work that we do. We are pretty pleased with what we're presenting to all of you here today, but I suspect that folks are going to have thought of things that perhaps we haven't fully thought of, or have differences of opinion about what some of the individual cost assumptions ought to look like. So we're really very much looking forward to your comments, again, not just on the rate side of things, but also on the structural changes that are being put forward as well. After we review those comments, we'll work with the state team to make any updates to the proposals that are warranted. And on my last slide, before I get to talking about what you actually want to talk about, is just again, an illustration of what goes into the rates themselves. So I've talked a couple of times about detailing our assumptions. Whenever we're doing HCBS type rates, including behavioral health services, there's going to be 5 core factors that we build in. 3 of them relate to the direct care worker, again, generically defined, so that would include like the CSPs in this example, but that includes their wages, their benefits, and what we refer to as productivity, or the amount of billable work that they can do. And then 2 of them relate to the agency's expenses, which we divide between program support and administration. So there's individual assumptions about all of that included in the rate models we'll be walking through here this afternoon. In addition to those 5 standard features of all Burns rates, there's going to be other service-specific factors as well. So, for instance, Kylie did a great job of explaining the key positions within this mobile crisis response framework: the dispatch coordinator, the supervisor, and then the staff delivering services like the CSP and peers. So you'll see specific assumptions related to the dispatch coordinator and the supervisor, for example, because a lot of this is community facing by the very name of the service being mobile. We have assumptions related to mileage, et cetera, et cetera. So we have these 5 fundamental components of the rates, but then there's other components that are incorporated based upon the specific features of the service. So I know I hustled through that really quickly because that's all background material, and I think folks are going to want to focus on what we're actually talking about from a rate or billing perspective, as well as from a rate perspective. Before I jump into that, I just want to briefly summarize what some of the thoughts were when we were developing these rates. Fundamentally, and this goes back to that mission statement I mentioned a couple of slides back, we wanted to build a framework that captures providers' expenses. Right, that's always our goal, so that's no different than what is typical, but we also know that there are some unique features to crisis services that we wanted to be thoughtful about, and these are things that all of you can recite better than I can, but that includes the unpredictable nature of the service, right? It doesn't lend itself to scheduling like a lot of other Medicaid-related services lend themselves to. There's also the need to have the capacity to provide the service, regardless of whether or not the community needs a service for a given shift or during a given day, right? In other words, we want to make sure that if a crisis occurs, that MaineCare, through its contract providers, has the ability to respond, but we know that they're not going to be responding every shift or every day, just because it's the nature of the service and the nature of crises. We also wanted to build ultimately a framework that allows us to increase the consistency in terms of how crisis services are reimbursed across department programs. So as you'll hear me talk about here in 1 or 2 slides, the rates that we've proposed are meant to apply both to reimbursement through MaineCare, but also meant to be the manner in which you get reimbursed for services through the Office of Behavioral Health, as well as OCFS, for folks who aren't MaineCare eligible. In addition to that, we had to take into account some of the geographic complexities of the state, and those are really compounded by some of the unique features I talked about earlier, right? That in some services you can do scheduling, and that's efficient if you're serving more rural parts of the state. In crisis, because you have to respond when people need you, there's less of that opportunity oftentimes. So we wanted to think about how do we build a rate structure that is fair for providers across the state, and then again, that's consistent across DHHS programs. And then lastly, we wanted to be thoughtful about, although this isn't necessarily a motivating factor, but making sure that what we're putting forward is using Medicaid funds in the most efficient and best way possible to maximize the use of federal dollars vis-a-vis state dollars. So without further ado, I wanted to start by talking about the billing framework. So I think Kylie made reference, I made some opaque references to changes being made, not just to the rates, but also to the reimbursement model. So Specifically, what we are putting forward for your consideration is a model where we have a bundled rate for that initial encounter. So I really liked Kylie's slide that she walked through that talked about the various components of that initial encounter, things like engagements and assessments and the like. And then in addition to that bundled rate, there would, which can also be considered a milestone rate. It's a lump sum payment for the completion of that initial encounter. There's a 15-minute rate that could be billed both for travel time as well as for the aftercare services, because we expect that the aftercare is going to look different on a person-by-person basis. We thought it more appropriate to keep a 15-minute billing unit there. Suffice it to say that the department will still be working on the billing instructions to differentiate where the initial encounter ends and the aftercare begins. But again, at a high level, and Kylie's slide detailed this a little bit further than my slide does, but the thought there is that encounter rates meant to cover the engagement through the planning and acute intervention. It could include some initial follow-up on that precipitating crisis event, but as a soft rule, not a hard rule, but as a soft rule, it's meant to cover that first 24 to 48 hours of the crisis response. As Kylie also explained, the aftercare can include elements of de-escalation and intervention without necessarily warranting another encounter billing. However, it's also true that someone could tip back into crisis for some other reason, and that would restart the encounter rate. So you could bill that encounter rate once again. So at the highest of high levels, that's the billing framework. There would be a rate for an encounter, which is a bundled rate that's supposed to cover all of the time that goes into providing that initial response. And then after that initial response, there's an aftercare rate that would be billed in 15-minute increments for those ongoing supports that an individual might need. And then the additional wrinkle to that 15-minute rate is it could also be billed for travel. And that would be travel both for associated with the initial encounters or travel associated with providing aftercare. And that's part of, and I'll talk about this, I think, in another slide, but that's one of the solutions that we've come up with to address the differences in the geography of the state, that in some areas you're going to be spending more time on the road than in other areas. In addition to that overall framework, in the last section of the slide is also very important, that the intent here is that all payments from the department be based upon this model. So this is not just a main care proposal, but it also covers payments through OBH and OCFS. So the short of the too long didn't read version of that would be there wouldn't be billing any longer for ancillary activities. The rationale behind that is when we built the rate model, we're intending to account for all direct care staff time, which includes indirect time and even some of the waiting time, for lack of a better phrase. So we've tried to think about the total activities that crisis responder, whether they're CSP or a PR, is going to do over the course of a year, divide those between how much gets lumped into the aftercare rates and the 15-minute rates with productivity adjustments, and make sure that all of those costs are ultimately captured. Of course, then, because we're proposing that this covers OBH and OCFS, that would still be through those offices using state-only funds. But in terms of how they pay you, the recommendation or the proposal that we're putting forward today would be that they'll be paying you through this encounter rate and the 15-minute aftercare and travel rate. Now I'll highlight some of the major assumptions that cut across both the encounter and the 15-minute rates, and then we'll talk about each of those specific rates in isolation. So as I said a moment ago, one of the things that we had to figure out is if we're going to build this framework where everything's not billed in hourly or 15-minute increments, we need to parse out, well, how much of it needs to be put in the encounter rates versus how much of it do we think is going to be billed through a 15-minute rate. And so we did analysis on information reported through the provider survey. We did some claims analysis, which, again, we had to make some assumptions because it's not as if today things are coded as initial encounters or aftercare. So we had to look at the timing of services and when they occurred in relation to others to make some assumptions about what would likely in the future qualify as an initial encounter versus aftercare. But ultimately where we landed is about 55% of an individual's total work hours would be associated with the encounter-related work, and 45% would be related to the aftercare and travel-related work. We got at that based upon the middle part of the slide here by assuming that the direct support itself would be about evenly divided between encounters and aftercare. So that time that's working with the individual or working on behalf of the individual would be half the time would be encounter related, half the time would be aftercare related. We thought that a lot of the work associated with things like collateral contacts, coordination, record keeping would be more structured or more burdensome on the encounter side of things. So the 80% of those activities are associated with the encounter rate. And then, of course, perhaps obviously, the travel time is all incorporated in the aftercare and travel rate. So when you see the rate models, you'll see how we start with a full-time work year and then break it down based upon those individual components. But the overall breakdown is 55% of the cost we hope will be recouped through billing of the encounters, and 45% would be recouped through the billing of aftercare and travel. Additionally, the ratio that we have that supervisory position built in is 1 supervisor is funded for every 5 responders, which are either CSPs or peers. In addition to that, because as Kylie said, there's the expectation there'll be availability of a supervisor at 24 hours a day, we also built in the cost of on-call time for every supervisory position. So we pay for 1 full-time supervisor for every 5 responders, but then we also assume that there's an an overtime cost associated with them as well. So a couple more slides, getting into the detail of the encounter rate itself. As I said, 55% of total work hours are a 2,080-hour work year, which also includes things like pay time off. But a 2,080-hour year, 55% is 1,144 hours. So that's how much we've built into the bucket that we expect to be reimbursed through encounter billing. In addition to that, the other major assumption we had to make is how many encounters is a responder going to be participating in per year, because we have their costs, based upon wages and benefits in 1,144 hours, but now we need to make an assumption about how that's going to be recovered by you, the provider agency. And so, again, we looked at information through the provider survey, we looked at billing through the claim system, and then we had some conversations about what we thought made some sense. And the assumption is that a given responder is going to participate in 150 initial encounters per year, which is about 3 per week. So in terms of how that works mechanically, and when I show the rate model, this will be probably easier to follow, but we have that cost and then we divide it by 150 to figure out what the per encounter expense is going to look like. A couple other wrinkles here, that we have a fully bundled rate for a 2-person response when that's 2 agency responders, and that is assuming an CSP and a peer going out and providing that response. But it could be a different permutation. It could be 2 CSPs, as an example, or in some circumstances, it might be a CSP and a clinician. In addition to that 2-person rate, we have a 1-person rate as well. That's meant to primarily support circumstances where the co-responder is not an agency employee. And so law enforcement would be probably the best example of that. So in that circumstance, that 1-person rate just includes the cost of the CSP, because the second responder is not reimbursed through this framework, because obviously they're paid for through law enforcement. A couple other pieces for the interest of completeness, although they don't drive the rates anywhere near as much as that first bullet does. We did fund 1 dispatch coordinator for about every 3.3 CSPs. And when you looked at Kylie's really helpful slide about the components, that's what we landed on for that dispatch coordinator position. We did fund them assuming that they are equivalent to a CSP. And then we also included funding for psychiatric support, like we have in a handful of other behavioral health rate models. So ultimately, what we come down to is a draft rate of about $1,170 per encounter for that 2-person response. Next rate is for aftercare and travel. This is much more traditional for those of you who've been involved in other Burns rate studies. So it's a 15-minute rate, takes into account things like staff productivity. Again, I've covered this already, but this rate would be used for travel as well as the delivery of actual aftercare supports. And that travel is either getting to the initial encounter or associated with aftercare. So in other words, when I talk about that $1,170 rate for the initial encounter, any travel associated with getting out there would be billed on top of the 1,170. The 1,170 is just for the staff time and obviously the infrastructure expenses. All the travel would be reimbursed through this model. Again, we wanted to explain why we thought this was appropriate here, whereas for most other main care services, we don't allow travel to be billed or we don't have geographically differentiated rates. And the reason for that is because as we talked about it internally, we really see some key fundamental differences in what this service entails versus most other services, not all other services, but many other services. And really that comes down to the unpredictability of the scheduling, as well as in some cases, generally low volumes. And so we want to make sure that when we're thinking about making the service available, that there's not any disincentives to people delivering services in the community. And we thought the best way to get at that was to allow that travel time to be directly billed. There'll be work to be done to define the parameters around billing for travel, but it's probably fairly obvious that the expectation would be that you take the most efficient route, that it shouldn't be circuitous. If we're not paying for the virtue of the staff person being behind the windshield, but to get out to the individual that they need to provide services to. Additionally, it's our expectation at this point that although the rate will be the same, there will be a different code or modifier specifically to track travel time. Now, furthermore, for this aftercare and travel rate, we have two different rates. We have one rate for CSPs and a little bit of a lower rate for peers, with the thought being that the peers are not going to have the same salary as a CSP is going to have. We talked about before a couple of times now the split of work hours between encounters versus aftercare and travel. So 45% means that we're putting 936 hours or 18 hours per week into the aftercare travel, not all billable. Because after you take into account the productivity adjustments, we're assuming that about 530 hours per year would be billed at the aftercare or travel rate. So the balance between the 930 and the 530 is 400 hours of non-billable productivity adjustments. And so that gets us then to a rate of about $34 per quarter hour for the CSP and about $27 per quarter hour for the peer. The rest of the presentation is covering some of the technical details about how the rates were set. So again, I'm going to try to hustle through this a little bit, but it's still important for all of you to understand, particularly as it relates to the cost assumptions. So if you look at Appendix A of the rate model packet, that's where we cover the buildup for the wage assumptions. As folks are now well familiar with us, we use the Bureau of Labor Statistics to establish those benchmark wages. Because that information is always published in arrears, we have to apply some inflation to bring it current. And so the most recent BLS data set was published in March of 23 and reflects May of 22. And so we've added inflation to get us up to July of 24. The wage inflation that we selected is based upon information from the Bureau of Economic Analysis. Its main specific data, it shows that the 10-year compound annual growth rate for net income, which is more or less wages, has been 4.2%. So 4.2% annually for 26 months is 9.3% in total. So we added that 9.3% factor to all the BLS data. Because the BLS doesn't include job titles like CSP or peer specialist, we had to come up with what we thought was the best fit for each individual position. That's what we show you in the top part of the slide. That for the MHRT, CSP, and the dispatch coordinator, the benchmark that we used from the BLS was the wage for substance abuse, behavioral disorder, and mental health counselors. For peer specialists, we use the wage assumption for psychiatric aides. And then for that clinician, because they're also playing that supervisory role, we use something a little bit different, and that's the social and community service manager position. In terms of the bottom line results, you'll see that in the bottom table here. So we're assuming an hourly wage for that CSP and the dispatch coordinator of $28.64, which works out to about $60,000 per year, in comparison to the $24, about $50,000 per year reported through the provider survey. The peer specialists were coming in at about $20.50, And then that clinical supervisor position, a little bit better than $34 an hour, so about 10% more than reported through the survey. For payroll taxes and benefits, we're using the same approach that we've employed in almost all of our rate studies, including the more recent behavioral health study. So the benefit package that we built in here is the same as what's built in for the other Section 65 services, for example. So we have 30 days of paid leave for the CSP and clinician and dispatch coordinator. And we have 25 days of paid leave for paraprofessionals, which in this study covers the peers, which is the same distinction we had in that Section 65 rate study. We're including assumed health insurance benefit of about $600 per month for every employee. There's some assumptions about take-up rates, but the idea is on a per employee basis, it's $600 with the expectation that some people aren't enrolled in employer-sponsored health insurance, but those who are enrolled, the cost is more than that $600. And then we include $200 per month for other benefits. Payroll taxes are even more straightforward, so 7.65 for FICA, unemployment insurance based upon the standard federal rate, and then the new employer rate for the state unemployment insurance tax and workers' comp, we have at 3%. This just illustrates the benefit rates themselves. Although all of the benefits are summarized in Appendix B, in the rate models, we translate that to a benefit rate, so what percentage of wages, and you'll see that that benefit rate varies by position. I always point this out because we sometimes get confusion where people ask, well, why are you giving more or less benefits to one position versus the other? The answer is we're not. Everyone gets the same benefits, but when we compare that to their wage, because some benefit costs are fixed, the ratio is inversely proportional to the wage. In other words, if you're making, like the slide here says, $50 an hour, that health insurance benefit of $7,000 per year is going to be a smaller portion of your compensation than if you're making $20 per hour. So I just point that out because a lot of times people expect to see the same benefit rate across all positions. But what we do is we give the same benefit package across all positions and then translate that to a benefit rate that varies based upon the wage itself. For productivity, this only applies to the aftercare and travel rate, right? Because the encounter rate is bundled. We're not differentiating between how much time is spent actively working versus with the individual versus doing collateral work that might not be defined currently as a billable activity. But in the aftercare travel rate, we need to account for the time spent that the time that staff spend that can't be billable. So after we account for that 900 hours, how many of those hours do we think are going to be billable? And as you saw in the previous slide, about 500. Again, wrapping up this slide, that the crisis intervention encounter rates based upon the assumption that the direct care staff complete 150 assessments per year. And as I said, that includes both direct and indirect time associated with the encounter. So you won't see productivity adjustments in that rate model. Instead, you just see the cost divided by that 150 encounter assumption. So this goes into more detail about what's specifically built into the aftercare rates. Again, we're assuming that 18 hours are spent on aftercare and travel. That's with the other 22 hours on average going to the encounter rate. And then we're further making assumptions related to things like training time, paid time off, and then other non-billable activities like some work that's associated with record keeping, what we call employer and one-on-one supervision time. So that's attending staff meetings or even counseling from your supervisor, et cetera. But I bottom line this earlier in the presentation, which is out of the 930 hours per year that's in the aftercare travel rate, about 530 of those hours are assumed to be billable, with the other 400 hours unbillable. And then wrapping up the high-level takeaways in terms of the rate models themselves, for administration and program support, we've included 15% for each. Administration are those activities that benefit the organization as a whole. So your executive leadership, your business office, human resources, et cetera. The program support are for other activities that are more programmatically driven. So sometimes that includes things like supervision, but we have supervision specifically called out. But that would be any of the other infrastructure that goes into your crisis management program. That's not the dispatch coordinator That's not the supervisor, and that's not the responders themselves, the CSPs and the peers. So in total, of course, that comes out to about 30%, which is how much we built in for other Section 65 services. And it's a little bit higher than the 28% that was reported through the provider survey. So I'm going to pull the rate model up in just a moment, but so I'm not going back and forth in terms of the presentation itself. I just wanted to wrap up the PowerPoint with the public comments. So this has been posted or will be posted, I believe, by the end of the day, the rate models that I'll show you here in a moment and some other supporting documentation. We're asking for comments to be returned in about 2 weeks. So that's by January 26th and submitted to Health Management or Burns. My colleague, Carl Matzinger, who's on this call, he's the person who's also coordinating the provider survey. So please submit your comments to him. As we talked about, and as you would have seen in previous rate studies, for those of you who participated, we'll ultimately put together a document that summarizes all the comments that we received, and we'll provide the department's position on each of those. If a change is made to the proposal, we'll explain what that change is. If we don't make a change, we'll provide the rationale for not having done so. And then we'll make the appropriate revisions to the rate models based upon the comments and what we think is meritorious. So let me show you the rate model itself, although I don't think I need to spend a lot of time on it because we've already covered the highlights in the presentation. But I'll just kind of walk through the mechanics of it. So the packet's only going to include the 2 rate models, right? The model for encounters, the model for aftercare and travel. Beginning with the encounter rate, we start with the cost of the responder, him or herself, so the CSP. The wage assumption is the $28.64 that you saw in the presentation, so give or take $60,000 per year. That benefit package that we described translates to another 27%, so that means the annual cost is right around $76,000. Then, and this is what's different than compared to most of our rate models, because we're doing this on this bundled basis rather than more of a fee-for-service model. We're looking at the total number of work hours, 2080, and allocating 55% of that to the encounter rate. Again, that's based upon provider survey, based upon analysis of claims data, and then based upon some internal conversations. So that means of the 2,000 hours, 1,144 need to be reimbursed through the encounter rates. If we assume that staff can do 150 encounters per year, that means per encounter, the staff cost is $278. I'm going to skip over the office space. It's important, but it's not that important in the scheme of things. And so then we do the same process for the second responder, which in this case we assume to be a peer. So a little bit of a lower wage. The annual cost is $57,000 a year. Again, we assume that 55% of their time would be reimbursed through encounter billing, which means that on a per person or per encounter basis, the staff cost of that second staff person is about $210 per encounter. I'll also note that for peers in particular, this is scalable, right? Your peers might not work full time. Maybe in some circumstances they do, but if they work half-time, mathematically, all that would happen is this $56,000 would be $28,000, and the 150 would be $75,000, but the cost itself on a per encounter basis would be exactly the same. So I understand that in some cases, not all these positions may necessarily be full-time, but from the way the rate model is designed, it really doesn't make a difference because we would scale back the number of assessments that they participated in commensurately. From here, again, skipping over the office space, we have the supervision. Works in the same fashion that we want to spread that supervisor's cost over both the encounter rate and the aftercare rate. So you're going to see a supervisory component to both, which means we need to apply the same factors. That if the supervisor is responsible for supervising that entire position, they're going to be responsible for supervision that's allocable to the encounter rate and allocable to the 15-minute aftercare travel rate. So it's the same 1,144 supervisory hours that get allocated ultimately to the cost of providing an encounter. But if we assume a 1-to-5 ratio, that means we're spreading that supervisory cost over 750 encounters, right? Because they're providing support to a larger number of individuals. I mentioned also a couple other components of this that we've included the cost of the supervisor being on call. So there is an on-call component to every single supervisor funded through the rate model. And then that psychiatric support, we're assuming comes in at an average of $3,000 per CS peer-to-peer per year. So again, that would be scaled up or down based upon the size of the organization, but if it's a $3,000 per FTE is how that is built into the rate model. Which means the cost of supervision and other supports is $160 per encounter. The dispatch coordinator, we fund entirely in the encounter rate. The expectation is that they're primarily going to be focused on triaging encounters that come in rather than doing a lot of supportive work for the aftercare and travel. So that's why you'll see that rather than that 55% threshold, we're doing 100%. Different from the supervisor, because we assume the supervisor's supervising both when aftercare is happening as well as the initial encounter. But for the dispatch coordinator, we thought it most appropriate to lump that into those encounter rates. And then from there, we're adding the 15% for administration and program support, which is how we get to that $1,166 total bundled rate for each initial encounter that's completed. And again, that's billed just once. Even if you have 2 of your agency staff going out, you're billing just 1 encounter. And then we have for the encounter that includes a single person, because you might be co-responding with law enforcement, the rate is $765. So the second and last rate model in the packet is for the aftercare and travel time. I've hit all the highlights of this already. So it's the same wage and benefit assumption because it's the same staff, right? It's just a question of how we spreading their time over the encounters versus billing through aftercare and travel. So 45% of a 40-hour work week is 18 hours. And then we make our assumptions related to how much time they're spending on other activities. So we're only assuming that they're spending 10 hours that are billable, including travel time. So the combination of travel time and aftercare would be 10 hours per week. Out of the 18 hours that ultimately get loaded into this rate model. So that inflates the hourly staff cost from $36 to $64 for the CSP. Then we've built in mileage. Again, in some regions of the state, the mileage could well be higher, but you're going to be billing more of this rate. So again, if more gets lumped into the amount of time you're spending on travel, you can think conceptually that you're going to be paid for more mileage because you're going to be billing more of this travel rate. Outside of that, we fund the clinical supervisor, the same fashion I explained a moment ago. So this is the other 45% of their time so that we're fully accounting for that supervisor's expense. And then the same 15% added for both administration and program support to get to a billable hour cost of $136 or $34 per 15 minutes on the CSP side and about $27 on the peer side. The balance of this packet are the appendices that walk through the wage assumptions, the benefit assumptions, and the productivity, which I'm not going to walk through on this call just to preserve a little bit of time for any sort of initial questions or feedback that folks have. But again, to recap, what we were really trying to accomplish is building a rate that allows us to layer all the expense of delivering services on top of the direct care staff, like we always do, right? We always include the cost of supervision and the agency administration within what you can bill for, but doing it through this encounter rate to capture more of the downtime. Because if you do the math, it works out to, I think, 8 or 9 hours per initial encounter, which in some cases might be the amount of time that's spent, but in other cases, it's probably going to be less than that. But that's a fully loaded rate that's taking into account all of the staff time, whether or not it's associated with actually providing that initial encounter or not. But then not thinking that was appropriate for aftercare because we expect there to be greater variability in terms of the extent to which people even need the support and if they need it, how much aftercare they're going to need. And then it also allows us to have a more flexible travel time rate so that providers who are serving more rural areas, who are spending more time on the road, have the ability to get paid for that time. So before I open it up to the community, I don't know, Olivia or Kylie, if there's anything you wanted to add to my remarks here.
No, I think that was was great. I look forward to hearing people's questions so that they can make the most informed comments in the next 2 weeks.
I don't have anything to add, Stephen. I think you did a great job. And yeah, looking forward to hearing from folks.
Thank you, Kylie. Thank you, Olivia. And so we did, like I said, I know I hustled through this. I hope I spent enough time on the structural pieces, which are different, but otherwise, I think the rate model itself is going to be familiar to many of you. And we wanted to reserve a little bit of time that we have left, another 15 minutes or so, for any questions that folks have. Dale.
So this question actually isn't for you. It's for Olivia, so you can breathe easy. Just in terms of the model, the structure, is that information also available for us so that that as we evaluate the rate structure, we can evaluate it against the model, including any restrictions? I know discussions about changing where assessments can take place. For example, they cannot take place, I don't believe, in hospitals and things like that. Is that information available so we're able to really evaluate the rates methodology?
Well, I'll say that certainly the presentation from Kylie is available. I think when you get to that question about the permissibility of different venues, I think it's really not in this structure. It's not that it's not permissible to deliver the service in certain settings from like a broad standpoint. It's this model is intended to support a community-based response. The way that we built it is to encourage response to be not, stagnant within a hospital setting or jail setting or, other non-community-based setting. I know what you're referring to is conversations regarding trying to get mobile crisis teams out of those settings and into the community more. So to answer your question directly, no, there's not going to be additional sort of strict guidelines on that front that accompanies this rate model. But in your comments, if you're having a hard time reconciling what you think you want, what we think we all understand to be the future state of the model against your financials, like please add that as a comment, because the cross office team will make sure that we take that into account as we do develop any more strict or prescriptive requirements. But I will say in general, it's not that that can't be a place of service for a response. It's just that there are, other restrictions around when a team is located within an emergency department and what that means for the assessment process and the credentialing of the staff from a licensing perspective, from a hospital perspective. So I will say that. I'll let Bree or others jump in if they want to add anything additional so that the team, again, so the crisis teams can evaluate this model and the billable units against what they're seeing.
Yeah, that's really my. I'm not arguing or challenging the decisions around that. It's more there's that practical. I can look at what percentage of encounters happen in certain settings, and if there are restrictions, that would need to be taken into account to be able to evaluate the overall efficacy. That's why I asked the question. Thank you.
Anyone? Oh, I'll let Sarah go, but after Sarah goes, I'm also just interested in any initial reactions, not to obviously your fiscal analysis, which needs to come later, but just to the structure in general as moving away from fee for service to something like this. But let's take Sarah's question first.
So this had a lot of information about individuals who have main care or who do not have insurance. I assume in any individuals we encounter who have private insurance, we continue to bill their private insurance as we do now.
Yes.
And so they will pay or not pay based upon what their insurance says they're accountable to.
Stephanie?
Sorry, muted and talking. Will this section 66 be replacing section 65 crisis services as we currently know it within the regulation?
Yeah, so what actually we're doing is pulling the existing section 65 services into section 6, what will be a section 66, a new section of policy that's called crisis services, and will cover the full continuum of crisis services. So we're not getting rid of any service, we're just changing the location within the main care benefits manual and then adding this new service. So you'll still have crisis resolution in there. You'll have mobile crisis teams, this version that we're talking about today, and then crisis residential all in its own standalone section of policy. We're doing that really for just administrative purposes, but also just because crisis services really are their own continuum. And Section 65, as you all know, is just a massive amount of services crammed into one very long policy, and it makes we lose some clarity, I think, when we have that massive of a policy. So we're just pulling all the crisis services into one together.
Thank you.
Sarah?
I think Michelle was first. I'll let Michelle go because I've already gone once. Go ahead, Michelle.
Take you up on that. I may have just like missed this with how fast things were going, but it sounds like all of this is going to guide a main care reimbursement for clients that have main care, and also guide reimbursement for uninsured individuals covered under our contracts with the state. Is that right?
That's what we're proposing, yes.
And so I was just curious as to how I'm assuming like all of these assumptions about reimbursement according to the number of staff you have will apply to that, which would probably guide the size of the contract or the thought about how much you would be billing the state grant for fee for service. I understand there's not going to be ancillary anymore. I'm just wondering how would like the size of your staff be determined for each crisis provider? Is that going to be decided through a competitive RFP process only, or another method?
Bree, do you want to take that one, or do you want to just have that in writing?
Yeah, sure. No, I know, as many of you guys know, this has always traditionally been a service that has been put out through RFP, and we do anticipate in that fashion moving forward.
So there won't be, not to belabor it, there won't be a specific formula for staff, for figuring out staffing for any one area. It will be more of a competitive RFP process that determines that. Oh, I think Bree froze.
Oh yeah, let's see first. Oh yeah, well, I'll just reiterate one point of it. So it is the RFP process, and that's what would be anticipated to kick off right after the main care rule is finalized, so that we're all understanding like this is the main care rule, and this main care benefit or this service is only going to be billable by those providers that are selected through the RFP process.
Yeah.
So but to your question about like whether staffing goes into, to me, your question is about like what is the criteria that the RFP scoring is going to use to establish who wins. I definitely don't know that from my perspective. So
yeah, that's not my question. My question was more like, I'm assuming there's going to be a limit to how much you can bill the state for fee for service for uninsured individuals. And that's going to be based on how many staff you have and the assumptions that they do 150 encounters a year and whatever, like all of these assumptions are. So like, how is that your staff size determined? How is your program size determined? How is the fee for service amount determined?
Oh, okay.
So yeah, so there'll be more. Sorry, I got booted out. Michelle, I think if you put that in written comment, we'll be able to have a more thoughtful response.
Yeah,
But
sure.
obviously, across the board, we've been working incredibly hard in regards to capturing data to really understand call volume. And so, as we move forward, we can, be more articulate with what we can share versus what may be going into an RFP process.
Gotcha. And yeah, I can definitely write that in the comment.
Great, thank you.
Thank you.
Sarah, I think the floor is yours now.
I'm glad I let Michelle go first because we had the same questions around RFPs, so she got my question answered.
Dale?
Just a quick follow-up to the insurance question. Is there anything built into the rate model that accounts for a percentage of insurance covered individuals? And the reason I ask that is that obviously with this rate structure, insurance providers are not going to pay that kind of reimbursement. And unlike other services, we don't have a choice of network, in-network, out-of-network. Somebody has insurance, we're gonna have to bill at their rate. So there will be a gap in terms of that financial impact, and just wondering if that's included anywhere in here.
It is not included right now.
Okay, thank you.
As Olivia said, any other initial reactions or certainly any more questions?
The initial encounter rate, the 1,166.44, is that per hour or per every X amount of hours?
It's neither. It's meant to cover that initial encounter, which is going to be a little bit different from one person to the next, but that's what Kylie covered in her presentation. There's like 4 components of the initial encounter. As a general guideline, the first 24 to 48 hours of response. I think it's fair to acknowledge that there's going to need to be more detail to define what falls into the initial encounter bucket versus the aftercare bucket. And if folks have thoughts about that as part of the public comment process, I know I would, I'm sure the department would love to hear about that. But to answer your question most directly, that's a milestone rate. That's the total payment for that initial encounter. It's not per hour. It's not based upon, a set number of hours. It's based upon the completion of that initial encounter.
I'll just jump in and say, like Kylie called this a thesis, and I know everybody's been working so hard on this for a really long time. And it seems like you all have been super thoughtful about it. So I'm not just kissing butt, but good job. Good work.
Thanks, Michelle. We have been very thoughtful about this, as have you all, and really heard the feedback about essentially what is trying to build a firehouse model of reimbursements that support this system of care existing appropriately and being high quality. The devil's in the details, as always. And so again, to Stephen's, the things that we're trying to prod a little bit of information on is to really, even in the structure of which we think is the right thing, obviously this encounter and then the aftercare billing, to think about your level of the level of effort your teams are putting in with an individual during the entire time with that individual, initial encounter, what we're calling initial encounter, and then later, how is that divided? What is the ebb and flow of that interaction with a person? Are you able to conceptualize how you would implement this model with additional billing instructions, but around when is it a new crisis event versus a continuation of a previous crisis event? Those are questions that not all of which will impact the dollars necessarily. They may, but they will impact billing instructions if at a minimum. So those questions and clarifications or recommendations, better yet, in your comments are appreciated to help us make sure that we put something out that is going to work.
Any parting remarks? Because we just have a minute or so left.
Stephen, I've had a request just to throw that initial encounter follow-up slide back up really quickly. Is it possible to do that just so folks can review that one more time?
The slide,
Yeah, if you could just stop sharing so I can share my screen quickly.
oh, yours, okay, so, yeah, I thought it was, by all means. It really is a lovely slide, Kylie.
I have to credit the Main Care Communications team. They came up with this amazing new Main Care logo and awesome template that I was able to use that helped me figure out a way to creatively represent a lot of complex information in one slide. So big shout out to Kayla and Sarah on the Main Care Communications team for the awesome work that they did. It's been a huge team effort.
I see Dawn's hand up.
Hi, thank you. Is it, when you publish the rate study details, can we include this slide, please? Is that possible? Okay, that'd be great. Thank you.
I think we can show the whole presentation, can't we, Kylie? Okay.
Yeah, the slide deck, both slide decks will be up there and a recording is posted as well.
Okay, Olivia, I think that takes us to 4:30, so I'll return it to you to wrap us up.
Yes. All right. Thank you so much, everyone, again, for sticking with us and doing all this hard work through all this process. Again, 2-week public comment period. Please stay in communication with us if there's anything that you feel like you need during that time period in order to submit your comments. Stephen and others are able to offer clarification to help you form your comments in a way that takes advantage of this common opportunity. Again, to submit the comments to Carl. This will all be posted tomorrow. You'll see it. You'll see an e-message that goes out, so you have everything that is being said and all the documents and the contact information all tomorrow. But also just stay in communication with us. We are obviously at this point trying to move this forward to make sure we can get this model implemented and serve the people of Maine under this new model. So thank you so much for your time and have a nice rest of your day. Thank you, Stephen. Thank you, Kylie.